So BJ writes the signs and cause of disease in the art of adjusting by hands, all subluxations as discovered by D.D. Palmer. Okay. Of the 300 articulations of the human frame, that's what D.D. wrote. Well, how many articulations are in the spine? Not 300. So what is D.D. talking about when he says the 300 articulations of the human frame? What's he saying, Jim? Extremities. That's from the horse's mouth. D.D. We're supposed to adjust extremities. Hi, Louis. This is Dr. Gary Russian, who drove 2 hours to get adjusted by me today so I can work on his frozen shoulder. How many doctors worked on you before you came here?
5 or 6.
Couldn't move the arm?
Nope.
Show Louis your frozen shoulder. All right, cool. But Dr. Gary here said that he'd lay down and let me demonstrate how my protocol on the medial meniscus tear. So, step up. Now the first thing I'll do with the medial meniscus tear is I'll take the VibraCussor and I'll take the adapter, the digital adapter, which is this, and I will put the nose cone adapter on here, so this gives it some space so I can get deep in the knee. Now the VibraCussor is also made by Impact, and it was designed to be a non-drug steroid, so what it does is increase circulation. It breaks up scar tissue. Whenever there's swelling in a joint, you're going to have calcium attract to that joint. If you have calcium attract to that joint, what's going to happen is the calcium is going to help create scar tissue in there and adhesions. If adhesions build up around the tear, then you can end up getting those locked knee syndromes. Anyway, so what we want to do is make sure that no scar tissue or adhesion builds up within the tear. And the only way we can do that is by using the VibraCussor, because the VibraCussor is going to break up adhesions, break up scar tissue, stop the calcium from attracting into the swelling area, because the VibraCussor is going to cause the swelling to go down. It's going to pump fluid out of there and increase circulation to the cartilage where the blood circulation is very poor. So what I'll do is I'll turn it on number 10. We have 11 speeds, and I'll put it right into the popliteal fossa, and I will bring the knee up, and I will just take it through. And this should be done about 2 or 3 times a day, because it's going to pump any of the swelling out of there. It's going to stop the calcium building up. It's going to stop any adhesions forming in the torn area. And I'm going to do that in order to decrease the swelling and stop any scar tissue or adhesions, and also keep the range of motion functioning properly while the tear is completely restoring itself and healing. Then, and I'll do that for a couple minutes, just a couple minutes. Then I'll bring the patient up and I'll flip them over. And the best thing to do for a medial meniscus tear is to do the bucket handle maneuver, and that's when you take the hand here and you bring the knee up, you apply pressure, and you let it go down straight. You bring it up again, apply pressure, and you bring it straight. You bend it again, apply pressure, using your elbow on the medial malleolus so you can actually apply pressure outward, and then allow the pressure of your hand to allow the bucket handle tear to flip in. If there isn't a bucket handle tear, this maneuver will still work well. Then, if I was going to use the ArthroStim on that, I'm going to take the ArthroStim, I'm going to set the ArthroStim on 12 impulses a second. I'm going to use the rib attachment, and again, while going through the range of motion, opening up the medial meniscus, again applying similar pressure, but doing it through 12 impulses a second. The next next thing I'm going to do is I'm going to bend the knee to 45 degrees. I'm going to check medial rotation, internal rotation, external rotation on that medial joint. If there's any fixation on internal rotation or external rotation, I'm just going to break that and make sure that's moving properly. I'll bring the patient up again, flip them back on their stomach. And then with the ArthroStim, I'll come back in, applying pressure to the lateral aspect of the knee, again, just taking it through its range of motion, allowing the medial aspect of the knee to open up. And then I'll apply downward pressure on the femur, lifting the leg up slightly and adjusting it through motion, and then do the same thing to the posterior tibia plateau while taking the knee through its range of motion. And then I'll finish up with the VibraCussor again, pumping any swelling, any fluid out of the knee, and any swelling around the torn tissue. Then I'll switch attachments to the edge and work the posterior of the calf, flushing any fluid and any trigger points in the calf muscle, which would be pulling across the knee joint, causing compression over the ripped area. And it would be best if that protocol was done about 3 times a day. I hope that's helpful, Louis.